Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Welcome back to another episode of Talk Dizzy to Me. My name is Dr. Danielle Tolman. I am a vestibular physical therapist, and as always, joined by my colleague and co-host, Dr. Abby Ross, who is also a vestibular physical therapist and a neuroclinical specialist. Today, we are very excited to have Dr. Habib Rizk on to talk about his personal experience with vestibular neuritis, as well as a physician who works with this all the time with his patients. Welcome, Dr. Rizk. We're very excited to have you on and talk about this today. How are you?
I'm good. Thank you for having me, Danny and Abby.
Would you mind giving our listeners just a little introduction about who you are and what you do?
I'm a neurotologist, and I'm currently an associate professor at the Medical University of South Carolina in Charleston. And I'm also a board member of the Vestibular Disorders Association.
Which is where I had the pleasure of meeting Dr. Rizk through Danny. So we have quite the connection going on here outside of Talk Dizzy to Me. You know, you hear often in all of the podcasts that we do, we always ask our guests, how did you get into the vestibular world? And a lot of them have anecdotal experiences personal to them before getting into the vestibular world as a clinician. But you, on the other hand, you were a clinician and then experienced vestibular dysfunction via neuritis yourself. So let's get into that a little bit. What is vestibular neuritis?
So it's an inflammation of the vestibular nerve, which is the 8th cranial nerve, and sends branches that serves the parts of the inner ear that control balance. And vestibular neuritis typically results from a reactivation of the herpes or the shingles virus, which can happen at any age. And it can lead to various levels of inflammation within the ear that lead to various levels of symptoms and various levels of dysfunction. But typically, this is a pretty acute and severe vertigo that ramps up over the course of a few days and then settles down over the course of weeks or months.
What were your first thoughts when you woke up with pretty severe vertigo?
I had a very classical picture, but it took me a while to realize that it took me at least a day. I thought initially I was having BPPV. I woke out of bed and I slammed into the wall. And I said, what's going on? Every time I moved to one side, it felt off. The other side felt fine. So I went through reconstructing my experience. I felt basically all stages of the nerve slowly going dead and then slowly going back up. That's why initially it was mild. But then by day 2 or day 3, it hit in all severity. And when you talk to a lot of vestibular neuritis patients, it's kind of like when you have a cold sore, and the day or two preceding it, you feel like there's something that's going to happen, like this tingling sensation at the upper part of your lip, and then suddenly the pimple and the sore comes out. Same thing with this neuritis when I reconstructed and reflected on how it worked. We even, since I was in my lab, we did a baseline function at the beginning of my symptoms. My gains, my function assessment was still around 80% on those first 2 days. And then it plummeted down to 20% as the symptoms evolved.
Wow, I was actually going to go in that direction next. So when you have a patient or yourself come into your office, what tests are you doing and what are you pulling out of their history to determine that this is a vestibular neuritis? And also I wanted to add that I had BPPV before, and it wasn't until I was formally assessed by a student that I was teaching that I realized I had it. But what was happening was I wasn't getting room spinning vertigo like you typically would. But when I would wake up or get out of bed quickly, I would do the same thing. I was running into walls, and I'm like, what is happening to me? And then within that week, I was training the student. He put me into Dix-Hallpike. He's like, Abby, I think you might have BPPV. So it's funny. You see this every day. You work with patients with similar diagnoses and symptoms, and yet you still didn't process immediately like you would think you would. This is what's happening to me. But anyway, back to tests and what you're hearing from patients when they come into your office.
Now, unfortunately, with vestibular neuritis, they rarely come acutely to my clinic because they are heading to the emergency room. When they're older, they want to rule out a stroke. When they're younger, they just want to make sure they're vomiting, dehydrated. So a lot of times by the time they get to my clinic, we are past the acute phase. Anecdotally, I had a case yesterday, which is like day 3 of the neuronitis, and typical picture of slowly developing vertigo and imbalance. I think it's going to hit that patient hard in the next couple of days, but I started them on prednisone. But I'm getting ahead of myself. Basically, when they come to see me, in the assessment of any dizzy patient, we need to make sure to understand what is the dizziness. As frustrating as it is to the patient, that is probably the most important part of uncovering what's wrong, is eliciting from the patient what type of dizziness it is. And we know that as clinicians, we need to classify the dizziness into 4 big categories. Is it a false sensation of movement or an illusion of movement? That could be a spinning sensation, a rocking sensation, a sensation of going back and forth, or forward and backward. All of those are vertigo type sensations, and they can be spinning or non-spinning. Is it a dizziness as in a sense of spatial disorientation, which leads us into a completely different direction? Is it an unsteadiness on your feet without any funny sensation in the head? Or is it what we call an oscillopsia, where things are bouncing up and down with movement or without movement? So with vestibular neuritis, the classical picture is vertigo, along with imbalance when they try to walk. As the acute symptoms start settling down and the nausea starts settling down, patients start eliciting much more varied symptoms, which I had the misfortune or the luck to experience firsthand and kind of understand what they were going through. For instance, every time I moved my head to the left, I could see like a visual lag, like my eyes are trying to catch up. I'm sorry, to the right. That's my side was on the right side. And then a few days later, every time I tried to move my head to the right or to the left, it felt like my head is a bobblehead. You hear that all the time. I feel like my head is a bobblehead because there was a disruption of the vestibular spinal responses. And there was basically no feedback from my cervical muscles to the ear to tell it that it's contracting or relaxing. So I could only feel it when basically my ear would hit my shoulder. I would be, a disaster to walk in the dark. I couldn't hold my toddler baby down the stairs. It was just too much to navigate the depth perception. Yes, so I went and bought a house that is 1 story. You can cut that.
What's interesting about
I had to, the first few days I had to go down on the stairs, on my behind. I couldn't.
Well, I think that speaks to a lot of what patients go through in terms of limited function. This is something, especially for peripheral dysfunction, right? Sudden loss of vestibular function in that vestibular apparatus is very alarming. It's very terrifying when that first hits, because it really does affect you in so many different ways throughout your day that makes it difficult to function normally. I think that's why a lot of people end up in the ER initially, because not only is it disturbing that the room is spinning and the people think they're having a heart attack or a stroke, but it's very hard to describe your symptoms. It's nothing that really anybody's experienced before until you've actually gone through this.
Mhm.
So what's interesting, and I think what's unique about your perspective, is you've actually been through this, and you can start to relate what some of the things that patients come in saying to how it actually felt. And you're like, yeah, it is like a bobblehead. Like, you really don't have control because you didn't realize how that head was moving in space. I think it's a really unique perspective to have, as a physician who's treating and working with patients who've been through this. A lot of times patients just feel like they're not understood, or nobody can fully understand what they've been going through, which makes it even scarier. So that definitely makes you a little bit more compassionate in that sense. So
I have patients who said, "I'm so happy you had it." I mean, not really, but really.
Not really, but really.
So when you first started experiencing symptoms, you were in the lab, you put yourself through some testing. And I got to first hear about this and see this at your vestibular conference up at MUSC in Charleston. It was almost a year ago now, which I can't believe. But I thought it was really interesting. So could you talk a little bit in clinical terms of what that testing looked like and how that panned out? And I'm very, very impressed that you put yourself through that much testing so many days close in a row, because that's not easy or fun.
It's not fun, but I felt necessary to have a firsthand account of the worsening process and the recovery process. I mean, basically day 2 of the symptoms, when I was in clinic, I had our physical therapist, Rebecca English, do a full physical exam on me. She laid me back. And I said, do you think it's BPPV? Because I'm dizzy mostly on one side. And we recorded the nystagmus that was persistently beating to the left side in all direction of my head and of my gaze, which immediately tells the clinician that there's something wrong happening on the opposite side, which was the right side. And then once we figured out pretty quickly that this was a vestibular neuritis, I decided to go through a video head impulse testing. And this is basically where we put goggles on the head and we jerk the head right and left while asking the patient to focus on a target on the wall. And when you have a vestibular deafferentation, loss of the function on one side, you will have a slippage of the eye from the target, and then the camera would measure a refixation of the eye on the target. And early on, that day 2 or 3 of my symptoms, there wasn't any significant drop in the function. You could see the saccades happening, but you didn't see the function of the nerve going below, very, very low. And at that time, I was at the maximum peak of my vertiginous symptoms, where I was really nauseated. I didn't feel well. Everything was moving. The visual lag with my head movement was bad. As my symptoms of vertigo started settling down and my symptoms of visual fixation and unsteadiness started ramping up, is when my head impulse test in the lab showed a complete loss of function down to 20%. And at that time, we did water test as well, the caloric test. And the caloric test showed only a 40% weakness, which goes to tell you that the battery of tests that we do from the vestibular system is complicated. And it's not one single test that will give you a full picture of what's going on. Based on the caloric, I had a mild to moderate dysfunction. Based on the head impulse test, I was close to 80% dysfunction. On top of it, we did what we call a rotational chair. All of those were done during the first 2 to 3 days and repeated at a weekly interval, then monthly interval up until month 8. Where we would do, we put myself in the chair in the dark and started moving the chair while tracking how the eyes are moving with the body and the head. And if you have an intact vestibular system, the position of the chair, which is the position of your head, the position of the eye should align almost with the position of the head at preset time points. If you have a weakness in one of the sides, the chair is going to be leading the eye because the eye is always trying to trail behind. And I had a significant phase lead early on that slowly shrunk and then finally got back to normal.
Now, you ramped up the testing for yourself for your own experiment, essentially, and to be able to share with your patients. But what are you doing in an office for a patient that comes to see you? You're not testing them as much as you tested yourself,
No.
day 2 to day whatever. But also, I'm curious, did you have gaze holding nystagmus with fixation and without fixation during this process?
Yes, I had. The nystagmus, though, was all same direction, beating to the same side, left side, in all directions of gaze. Upward gaze, downward gaze, left gaze, center gaze, and rightward gaze. Yeah. And I have a video of myself, recorded that I put in my lectures.
Very cool.
And it's actually rare to find it, to catch a neuritis, so acutely.
Right, especially in your office, because you mentioned you don't typically see patients that acutely.
Yep.
So for your regular patient that's coming to see you, or your classic patient that's coming to see you, what testing are you doing on them?
So other than the complete physical exam, which can give you basically the diagnosis, like that gentleman I saw yesterday, I always get a hearing test, even when they don't have hearing complaints, because sometimes, especially in the shingles variant, you can have more than one nerve that is dysfunctional, and the vestibular nerve and hearing nerve and facial nerve are all close to each other. So I also always double check on my clinical exam that there is no facial palsy. And then because I have it available, I do the video head impulse testing because it's a quick, fast test that we can do that will basically confirm or infirm my suspicion of a weakness and to which side and to what extent. Those are other than the clinical exam, the two tests that I would do are the hearing test and the video head impulse test. Now, because I see most patients after they've been worked up, almost all of them are coming with an MRI. What I did with myself, I never got an MRI for myself because my hearing test was normal. So whenever a patient does not have a hearing asymmetry and a classic picture of vestibular neuritis, I don't obtain an MRI unless there are some red flags like a facial palsy or one-sided tinnitus that is not going away or those kind of things. So in the classic picture of a vestibular neuritis, I usually don't get an MRI acutely.
I like that you do the video head impulse testing because we can do head thrust testing at bedside, but there are a lot of times where there's covert saccades that we can miss, especially if they're compensating well following, the onset of their symptoms. But with the video head impulse, you can also test additional canals to see if there's different, whether it's superior vestibular nerve or inferior vestibular nerve involvement, which can sometimes be a little misleading. You can have that hypofunction, just not something that's easily seen in that head thrust test, leading back to your point where there's not one specific test that confirms a diagnosis. It's a collection of tests that look at different frequencies of issues that kind of pile up and create this picture of what we're looking at. So that's really cool that you're able to quickly get that video VHIT system on and get patients through that testing. Is it pretty well tolerated by patients when they go through VHIT?
Test is very well tolerated. Now, I want to preface this. You don't need that to make the diagnosis, but when it's available and you're going to be following the patient, I always like to obtain it at a baseline to compare at time points later on if they're not recovering like they should. And it's very well tolerated. We even teamed up with the stroke neurology team and their physical therapist who examined patients in the emergency room recently and did a feasibility study where their physical therapist does a video head impulse test in patients coming for stroke assessment after they've done their MRI, so that we don't delay treatment. And it was surprisingly very well tolerated. So even in patients in the middle of a stroke workup and who are extremely vertiginous, we were able to get meaningful data, and they're presenting it at some of the stroke conferences that they're attending. So it might become also part of our flow in MUSC for stroke workup. It's already implemented in other centers, I know, for stroke assessments. So it is very well tolerated. It's not like a caloric test or a rotational test. It's a really quick and easy one. And again, you don't need it. I don't want patients to think that if they don't get it, they're not getting the right thing. But if you have it, that's an extra tool that comforts you in your diagnosis, especially in inferior vestibular neuritis, which can have much more subtle symptoms because it's a smaller nerve and a smaller subsection and portion of the inner ear. So sometimes I am 100% convinced it's a neuritis, but then I do my bedside head impulse test and it's really equivocal or negative. And I do the head impulse test and I see a posterior canal weakness. And I say, okay, well, that's why it's not as evident.
So interesting. And you're so lucky to have all that technology available to you because you're right. A lot of clinics don't. And it's a good thing that you don't necessarily need that to get the diagnosis. Thank you for reaffirming that. Hey guys, it's Abby here. Unclench your jaw, relax your shoulders, take a nice deep breath. Doesn't that feel better? Thank you so much for listening to Talk Dizzy to Me. One of our missions here at Balancing Act Rehab is to spread awareness about vestibular dysfunction, and the best way to do that is with your help. We'd be so grateful if you took a moment to subscribe, review, and share our show with someone you think would benefit from hearing our conversations. Let's get back to it. Let's move into treatment. So, would you say that you treated yourself the same way that you would treat patients? And did you go see Rebecca for vestibular therapy?
Rebecca would tell you I was not a very good patient, but she was with me almost every day in clinic, and she would make sure that I'm doing my exercises. I had my black dot in my office for the longest of time and doing my VOR and my metronome. I I do treat my patients. I decided to follow what I would tell a patient. So I did a hearing test. It was normal. I did not get an MRI. I wanted to give myself prednisone, which is kind of a not controversial, but the jury is still out about how important is prednisone in vestibular neuritis, which even though it's a similar pathophysiology to Bell's palsy, the studies so far did not show that high dose prednisone early on and antivirals early on would change the natural history of this. There's a couple of studies that showed that the symptom relief is the same, whether you take prednisone or not, but the endpoint on caloric testing, so patients who got prednisone early on tended to have a better residual function at 1 year compared to those who didn't. I did want to get myself prednisone, but at the same time, luck of the draw, I had a kind of a small abscess in my sebaceous gland of the lid, like I had a sty, and I figured, I don't want it. I decided not to take prednisone, and but when I see patients early enough, I always suggest prednisone early on. I don't think there's any harm in somebody who doesn't have any contraindication and you see them early enough to give them a 10-day course of high-dose prednisone.
What did it feel like to start your vestibular exercises?
It was, I had been treating patients for at least 2 years since I had graduated from my fellowship by the time this hit me. And I really appreciated how, we tell patients, oh, go do PT, you're going to be better. And commit to it. We know it sucks, but you have to do it. But we don't really know how much it sucks until you actually start doing it. And I was lucky. I was luckier than most because I had a physical therapist every day with me. And, it happened also on a week I was scheduled to do a sac decompression surgery and canal dehiscence resurfacing. And my assistant was calling my patients, telling them, Dr. Rizk is dizzy. He cannot do your surgery. I mean, those kind of things also where patients get, really get in their head that, oh my God, people are going to think that, I'm like, she's dizzy. Like the connotation of the word dizzy is really negative. One thing that Rebecca had taught me early on, because I didn't want to stop and sit at home. It was just not what I wanted to do. But I was worried that walking in the hallway of the hospital, I looked like I was drunk. I actually looked like I was drunk. So I walked next to the walls with a finger on the wall. It was probably a very weird sight to see me walking down the hall, but that helped me a lot because that provided a lot of grounding and understand what I needed from a muscular standpoint to sense, get basically proprioceptive feedback. So I did my physical therapy in a way not in a session sitting down all the time, but by incorporating those tips by moving through my daily life.
So many providers often prescribe Mecline to patients with any sort of dizziness or vertigo symptoms. Do you do that?
I give it when the symptoms are really debilitating early on, with the clear understanding that you have to stop it and to not use it as a way to prevent the symptoms. And personally, I only used it the first 3 to 5 days. When I was dizzy to the point of vomiting, I would take a Phenergan. I just needed to kind of, when I take it, and lay down. Phenergan is slightly stronger than Mecline in my experience. So yes, it's okay to take Mecline, but as needed and for a limited period of time. And I never give a patient more than 10 tablets of Mecline for a neuritis. Even for my patients with Meniere's disease and migraine, I give them 10 or 15 tablets at a time, just to have, so that they know that it's a limited amount, that they need to really use it sparingly. Most of them know they can get it over the counter, but I tell them this is my way of basically letting you know that you need to be really asking yourself, do you really need to take it, and not use it and pop it as if it's, a sugar candy. And it's all still frustrating that to this day, I see patients on 3 times of Mecline a day for over a year. I mean, that just makes my mind, I don't know, just very aggravating. I still see it to this day.
Well, I mean, the challenging thing about being on Mecline long term is that you're suppressing that vestibular system that needs movement and needs information to learn how to feel better. So, it's really important in those early days to allow that organ to function and feel and sense in order for your brain to kind of make sense of what's going on and reorganize all of that information. How long did it take you to start feeling back to yourself, back to being able to function normally and not worry that people thought you were walking drunk down the hallways?
It took me 2 to 3 weeks to really feel like I'm in control, knowing that there were still situations in the middle of the night I had to be careful. I couldn't move my head quickly. I wasn't comfortable going down the stairs holding my kid without holding on. So those kind of things took several weeks. Driving was fine. Driving, surprisingly, you're more focused, you're grounded, you're holding the wheel. And actually, it was a kind of therapy because you're moving your head all the time and you're practicing it. So obviously, I was careful initially and then ramped up as I started to get better. But the thing that I noticed that also was kind of an eye opener is that every time I had sleep deprivation or fatigue, all the symptoms came back. So there was also during my workup where I was testing myself, there were times where suddenly I was like a week ago I was good, and then suddenly my gains on the head impulse test went down. It was at the end of a clinic day, or I was on call and sleep deprived, that every single symptom resurfaced except the vertigo, but all the imbalance, the fuzziness, the visual lag would ramp up. One very telling example, I had woken up early to travel to the American Balance Society where I was giving a talk. It's in Phoenix. It's a 5.5-hour flight, and I had to wake up at 5 a.m. or get to the airport at 5 a.m. By the time I landed, I couldn't stand straight. Like, I got out of the plane and it took me about 2 hours to be able to get to the conference and give the talk. It was, again, a big eye opener. And I think that's why some patients end up being really recluse. If they're not having a good understanding of what's going on, they don't have a good diagnosis or a good idea of, okay, those are ebbs and flows that you can control and manage, and this is not going to be your life all the time. It's no wonder that patients who are misguided end up, the way we see them sometimes, and we say, not out of vanity, but we say, we wish we've seen you earlier. It didn't need to take that long.
Yeah, exactly. I mean, that was something that you had working in your favor, that you had access immediately and the knowledge that you have to be able to treat effectively right away. I'm so glad you brought up the sleep, and I'm curious, not to put you on the spot, but I'm curious, did you have conversations with patients about what they might experience even when they're doing better and feeling better? Did you have conversations in terms of prognosis with them before experiencing when you had lack of sleep, your symptoms came back or got worse, or you felt like you regressed a little bit? Was that something that you thought about before actually experiencing it?
I had thought about sleep causing dizziness, but I didn't understand to what extent it is associated with vestibular decompensation. A couple of years after this event, we wrote a chapter in the otolaryngology clinics, and part of it, the chapter that I had to write was on quality of life, and I made a big portion of it to address sleep. And not only for neuritis, but also in any vestibular disorders, you have to make sure that the patient does not have sleep apnea. And in my experience over the years, whenever I was stumped by a patient coming who's dizzy and I couldn't find any vestibular condition that was convincing, two things I always end up screening for: sleep apnea or a lung disorder. Like, I make sure that they're not deconditioned from a lung standpoint and having some hypoxia. So over the years, I started having a better understanding of how much sleep is a potential driver of symptoms, but also of decompensation of a vestibular condition. And I make sure to mention that to patients as much as I can. I mean, we're all guilty of having so little time and sometimes focusing on cliff notes of things, but I make sure to address it during their follow-up with me at some point, if it's not at the first visit.
What I think is interesting about what you had just kind of said and painted a picture of is that your improvement wasn't linear. It wasn't this steady progress of just, better and better every single day, that there were ups and downs, that there were things that affected your symptoms. There were things that made you feel worse that would kind of set you back a little bit before you got better. And I think that's something that a lot of vestibular patients are surprised by. They get very panicked when they feel themselves taking a step back because they think that something's getting worse and they're not doing something right. So I think it's really interesting for you to describe that feeling of taking those different steps in different directions as you were trending in the right direction.
Yes, yes.
Are there other types of coexisting vestibular dysfunctions or neurological disorders that can coincide with vestibular neuritis with patients?
It's very common. About 40% of patients with vestibular neuritis will develop BPPV several weeks later. Also, it's always hard in a first episode of neuritis to differentiate it fully from a migraine, from a vestibular migraine disorder, or a Meniere's disease episode that was not associated with all the other symptoms. Even though with Meniere's, usually it's short-lived and never lasts several days. And interestingly, I had motion sickness my entire life. So it's like something that I was accustomed to have motion sickness. And I had migraine headaches once or twice a year when, after a long fast or, a pretty sleep deprived week or something like this. But since I had the neuritis, I would get vestibular migraine attacks every time there's a storm or a hurricane on the coast. It's just clockwork since 2017, since my neuritis. Every time we have a hurricane coming close to us, I wake up in the middle of the night and I'm like drunk, and it's kind of disconcerting. And again, another element for me that to pay attention to. Now, it's not necessarily that it's a coinciding condition, but it's important to differentiate that. But basically, BPPV is the one condition that always be on the lookout for during the recovery process. If a patient presents, oh, my dizziness has come back, but it's slightly different, always do a Dix-Holpite. And that's one point I'd like to make. Even in my patients where I already have the diagnosis, just by looking at their eyes and I seeing the nystagmus beating to the same side, I always do a full vestibular exam, because not more than 30% of the time, you have patients with multiple vestibular conditions. They tend to attract each other. And a patient with long-lasting Meniere's disease that you've been following for a long time can still have BPPV. A patient with neuritis can still have BPPV. So one of the many things to look out for.
I'll attest to that. I did have a patient who came to me acutely directly from the hospital for bedside evaluation. And this was the first time that, we've been hearing it. Make sure you always do your positional testing, always do your positional testing. He came in third degree, right beating nystagmus, dizzy. I mean, he was feeling awful. And I still put him through positional testing. And wouldn't you know it, he also had posterior canal BPPV.
Yeah.
So, I mean, we addressed the BPPV right then and there, which actually made him feel a little bit better. So we get to ease a little bit of that suffering in that acute stage, but you are absolutely right. I have seen it firsthand. I can attest to that. Make sure you're always doing your positional testing.
And it's a good prognosis. If they have BPPV, it means not their entirety of their nerve is gone. So I tell them, okay, that's the silver lining. It's miserable, but at the same time, a good news.
And very treatable. Okay, so based on what you've been saying, I'm curious if your answer to this question has changed when patients ask you, because everyone wants to know, will I feel 100% better? How do you answer that?
I tell them you'll get close. Even now, 7 years after the fact, when I work out, when I exercise, there's always one side that is, I feel off in certain tasks, even though you wouldn't know it, but necessarily. But I don't feel in control when I have to do things that involve a single stance on my right side. I do martial arts with my kids just to kind of motivate them to continue. And there are certain forms where I look like, a clumsy old guy, but it's related to my vestibular condition. It's, there's a lot of things where you have to turn and do a move, and always on one side, it's better than the other. It's kind of never misses. And it's related to this because I never had it before. So there's subtle things that are related to balance that don't affect my day-to-day life, but I feel like they're not like before. But fine. I mean, life is good and we can make do and we can continue working and practicing on that.
Was there anything that really surprised you throughout this entire experience that you didn't expect or that you didn't anticipate?
I didn't anticipate how how quickly. So the first thing that amazed me is that mechanism that I always tell students and patients about, the cerebellar clamp mechanism. The first 3 days you're miserable, and then the brain realizes the asymmetry between the two sides, and suddenly your vertigo goes away. And it is like this. It is sudden. It is like you wake up one day and suddenly there's no more spinning. Like this one is a major shift from one type of symptoms that are absolutely miserable to a slightly less miserable type of symptoms, but more manageable. And you know that your brain is doing this wonderful thing of trying to compensate. And it's also what was amazing to me about how important the vestibular. We know it as scientists and clinicians, but we don't know to what extent it affects the life of somebody. And we read about the vestibular spinal reflex, but we don't understand what it means to feel like I'm falling all the time, what it means to feel like my head is on a bobble stick, that it's not standing straight. And that makes me realize how much proprioception in the neck is dependent on that vestibular feedback as well. And it was amazing to me. My family would walk on me, seeing me sitting next to a mirror and testing myself like this to see how much I would take to habituate. And again, it was in hindsight, a fascinating experience to go through it all and being perceptive of my symptoms and making notes of, what it could be to explain them. And what this allowed me to have is expand my own vocabulary when I ask questions to patients. When I see them struggle to describe to me, I tell them, okay, listen to me. Is this like this? Is this like that? Because I had spent a lot of time thinking about my symptoms and finding words about each one. So I guess that was the most fascinating part of it.
What a way to build rapport. I mean, so many times when patients come to you, they might think that they're a little bit crazy when they tell you some of the ways that they're describing their symptoms, but you can probably fill in the blanks for them now when they're reporting how they're feeling, which is, silver lining for you. When patients have a vestibular event or develop vestibular symptoms, often there's psychological aspects that accompany it, like increased anxiety. Did you experience that? And if you did or did not, even in the slightest form of, I'm worried that people might think I'm drunk at work the way that I'm walking. How do you recommend patients combat those more negative thoughts and anxious thoughts?
It's a hard question. And I continuously said to my wife, to Rebecca, like, I know now why patients are so anxious about this. I was worried that I would drop my daughter, who was 1.5 years old. Like I was a little bit, for a few days, I just would refuse to hold her. And I knew what was going on, and I knew it was self-limited. For people who don't know that it's self-limited, who don't know that there is a recovery process, I can understand. And that, I can understand that they would be trapped in that, vicious cycle of negative feedback and emotions. So the best thing to do is, and most patients do it, they go to the emergency room, they seek care, and you've got to hope that they don't get dismissed. But to this day, I still hear patients telling me that their physician said, oh, you're never going to get better. Actually, just today, I had a patient was told that after a labyrinthitis about a year ago. So I guess the shame that people hide behind can sometimes make things worse. You need to explain your condition and make it visible. And yes, it's okay for people to look at you and say, something is off, but we know they're not making it up because they told us and explained what's going on. A lot of times is when people don't understand is when they judge.
Do you have any tips or recommendations for improving recovery and overall vestibular health for people who might be going through something similar?
Staying active. The worst thing you can do is lay down, limit your head. I actually actively sought the discomfort of the head movement because I knew this was going to facilitate recovery. Again, I would sit in front of the mirror and shake my head while looking at a target. Again, my physical therapist thought that I didn't do it hard enough because she was tough on me. And but I think I did. And so just make sure to not avoid the movement that will make you feel off. Now, yes, some patients are extremely nauseated, and there are medications you can use like Zofran to reduce the nausea. Put an ice pack on your neck. Do certain things that will take ginger or ginger tea. Those kind of things that will allow you to reduce the nausea, but not the discomfort, so that you can continue moving and stimulate the vestibular ocular reflex.
Well, Dr. Rizk, you have quite the unique position as both a provider and a patient. And I'm so thankful that you came on the show tonight to actually appeal to both our clinician and our patient audience. And I want to mention, I have gotten this feedback multiple times as a provider. People say providers make the most non-compliant patients. And it's true for myself too. What I preach to my patients, I don't always follow the same rules. So I'm with you there. Any parting words, any place for patients to find you, any resources you'd like to share with our audience before we go?
I think there's an excellent resource for patients has always been the Vestibular Disorders Association website, vidavestibular.org. That is the one place where I think you would have the best evidence-based terminology and facts about vestibular conditions, instead of going through the quagmire of Google stuff that give you sometimes unrealistic answers. As for me, I'm in Charleston, South Carolina. I'm always happy to see patients there, and my email is rizkh@musc.edu. If anybody has any questions, clinicians or patients, I'm happy to answer them.
And if you're not anywhere near the Charleston area, definitely head to vestibular.org and check out their provider directory to find other clinicians and physicians that might be closer to you if you need to find someone that can help diagnose you and work with you to address your symptoms. But thank you again, Dr. Rizk. We were so happy to have you on and have you share your story. We hope you guys enjoyed this episode, and we'll talk again soon.
And I want to add one more note on the topic of VITA, the Vestibular Disorders Association. Why don't we give Dr. Rizk a shout out, because he is currently the president of the board of directors there, and he puts in countless hours every week for free, volunteer, for patients all over the world to gain access to the resources that he just mentioned, and also the provider directory that Danny mentioned. So thank you, Dr. Rizk.
Thank you.
Thank you.
Thank you both.
Good night, everyone. This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.